Before I introduce our speaker, let me introduce myself and welcome you all to Sovereign Health. I'm Dr. Larry Snyder, and I'm the medical director for Sovereign Health California in San Clemente. Sovereign Health is now a 132-bed facility that extends between Lake Elsinore, Lake Arrowhead, and San Clemente, and we are also opening a new program in Culver City, which for outpatient mental health dual diagnosis treatment. We've been in existence now 4 years and have grown from 6 beds, so it's been quite a growth spurt. Recently, we've also been licensed for residential and detox treatment in 2 of our facilities in San Clemente, the program in Culver City has just recently opened, and the one in Lake Elsinore will open on the 15th. So, a lot of activity. But we welcome you all here, and glad to see you for the monthly CEU conference. It is my pleasure to introduce our speaker for today, Dr. Sonnee Weedn. Dr. Weedn is a clinical and forensic psychologist who practices in Novato, California. And for those of you who don't know where Novato, California is, it's in a beautiful part of the Bay Area, just north of Marin County, Sausalito, I suppose. She's been in private practice since 1980, and she treats a variety of individuals, couples, and families, maintaining 5 weekly therapy groups. Dr. Weedn treats trauma survivors from adult children of abuse to combat veterans, and she uses an holistic approach that's tailored to the individual situation. In addition to her private practice, Dr. Weedn consults on a variety of mental health and addiction treatment entities in the area. And she also works with education for healthcare professionals. She has written an award-winning book titled Many Blessings, A Tapestry of Accomplished African-American Women. And among other things, this is a testimony to creativity, resilience, and inspiration for those who have faced and overcome trauma in its many forms. Without further ado, let me introduce Dr. Weedn, who today is speaking on trauma resolution.
Well, good afternoon. I'm very grateful to be here today, and I'm glad to be talking to all of you. I met Marissa in Northern California at a reference dinner, and she invited me to come and speak, so thank you, Marissa. As Dr. Snyder said, I'm a clinical and forensic psychologist, and I've been in practice a long time, so I've seen ideas and treatments come and go over the years. I really I didn't know anything about trauma. I didn't know anything about addiction. And when I began as an intern in 1980, all of a sudden my office was filling up with men who were combat veterans from Vietnam, Vietnam era. The war had ended, I can't remember what year, I'm thinking 76, around that time. And they did not present, they didn't come in saying, you know, I'm a combat veteran, I have PTSD. They came in with a variety of complaints, a lot of relational issues. They had wives and girlfriends who were sick to death of them and leaving them. They had drug and alcohol problems, although a lot of them didn't really identify that. And so, you know, I didn't know anything about drugs and alcohol, but I would just ask a lot of questions. And, you know, you say you have difficulty going to sleep at night. You know, how do you put yourself to sleep? Well, I have a pint of vodka that I drink, and then that. So I began to learn about trauma from all of these veterans who were so kind to teach me. So I decided today, I found, please be patient with me while I learn to work this little device. I found a lovely, well, it's not doing it, come on. Can I touch it and it'll change? There it is. So much for technology and the magic wand. Isn't that amazing? You touch it, and I was watching the guy set it up, and he was touching all these different things. It was really pretty cool. I found this quote. You know, Dante, I forget how old, when Dante was writing, but it's very old. Midway this life we're bound upon, I woke to find myself in a dark wood where the road was wholly lost and gone. And I really liked that because I think it's what happens with trauma. When trauma comes to our attention, usually people come in because they feel like they're in a dark wood and they have no idea where they are or how in the heck they're going to get out. So I made a couple of notes that I wanted to read to you before I go on. By the way, you have my slides there. You're welcome to them. Did you know that June is PTSD Awareness Month? How about that? Catherine Sebelius at the, whatever the health department is called, HHS in Washington, D.C., declared this PTSD Awareness Month. So I thought that was interesting that here I am talking about trauma on PTSD Awareness Month. So what I'm going to do today, an hour is not a very long time to talk about trauma. We could be talking for weeks about trauma and trauma treatment and the varieties and so forth. So I'm going to try and give you an overview. I believe you also have in your handouts a separate, Marissa, they have a separate chart. Good. Because this, good. So there's a chart there as well. So trauma, whoops, go back. Go back. Oh, I'm going the wrong way? No, it's going the wrong way. Okay, there we go. Thank you. You know, when you hold the magic wand upside down, it doesn't do what it's supposed to. Or it does something you didn't expect. Trauma, by definition, involves major losses. All losses are not traumas, but all traumas involve loss. So if you think about, you know, the patients that you're treating, it's so important to be looking at what the losses are, you know, because that's where the work is going to be. And I think it's important to say what is lost to me may not be lost to you. So it's important also to look at the whole individual and to understand them holistically so you can see what it is you're going to work with in terms of trauma. So trauma has to do with unusual events. Does everybody know the DSM definitions for trauma, post-traumatic? Yes? No? You do? Okay, good. So unusual events involving loss to the individual. Death. Of course, somebody who's dead doesn't come to your office, but if there's been a sudden death that they did not expect, you know, or they've been a witness to maybe the visceral aspects of death that were traumatizing to them. Maybe it's the loss of a particularly important individual in their life, or an individual that triggers other kinds of feelings in them, memories, etc. Loss of body parts or function. Some of the veterans I treated had lost limbs. I see men sometimes who've had surgery for prostate cancer and they're no longer able to be sexually active in the way they used to be. That's a big loss. Loss of a job. I'm not particularly seeing this in my practice at the moment, but some years ago I had a lot of executives from Chevron in my practice, the refineries across the bay, and many of them lived near me. And many of these men had begun working for Chevron right out of college, and there was an expectation that they're going to rise right to the top, retire with at least $1 million, probably several $1 million in their retirement. And that was really kind of the promise if you were at the executive level. What happened was, I believe it was in the 80s, late 80s, there's a big lawsuit. Women in Chevron brought a lawsuit, discriminatory lawsuit. Many of these men, although they didn't lose their jobs, they lost their place on the ladder as women began to be promoted and all that goes along with that. So that was trauma for them, something that had been promised. So it wasn't the loss of a job, but it was a loss of a dream. Loss of one's home. I don't know how it is here. In my area, very, very wealthy people are losing their homes. Perhaps because of job loss, or things did not go the way they thought they would. They lost money in the stock market. So loss of one's homes. And in the surrounding area around the Bay Area. There are whole neighborhoods that are empty because houses have been foreclosed on, so loss of home. But oftentimes what we're really seeing in our offices, or in my office anyway, is the loss of one's trust in others or in the safety of the world. So I think I'm going to stop here for just a minute and talk about that a little more. The essence of trauma is the abrupt disintegration of one's inner world. So the first veteran I saw, and I'm going to be talking about him throughout this presentation off and on, his name was Ed. And he came to see me because he was having problems with his wife, who was leaving him. And he did not present as having drinking problems, but he's the one who said, I can't sleep. And so I drink a pint of alcohol every night to go to sleep. And that was on top of whatever he was drinking during the day. His work was that he was a used car salesman. Yeah, that's right. And he was quite successful at it, actually. He had a good job. Now, I think I'm going to back up for a minute and say, whenever I have any new person in my office, it doesn't matter why they're presenting. In the very first session, I do a very extensive genogram. And I'm doing that because I want to get a sense of where does this person come from, who are their parents, what kind of work did their parents do, where did they grow up, were they middle class, were they lower middle class, what's the story, how educated are they, was there abuse or neglect, I want the whole story. So Ed came from an alcoholic family. Both of his parents were alcoholics, but he didn't see that as a problem. That's just the way it was, and it wasn't any big deal. At 19 years of age, he enlisted in the Marine Corps. This is Vietnam era now. And so it's important to know, because I still have Vietnam veterans coming into my office, even though, they're my age. I'm 65, and they're in their 60s and sometimes 70s. At that time, Marines went 13 months. All the other services, 12 months. The Marines are the few, the proud, so they stay longer. And Ed had a perfect service record. He was he was in the infantry, he was in combat. And he didn't tell me a whole lot about that. He didn't really want to talk about exactly what had happened, but he did say, so I got home, and wherever it was that he was stationed, a Marine Corps general came, and everybody stood in their uniforms on the parade grounds for the general to review the troops. And as the general passed by Ed, he could see his combat ribbons and so forth, whatever the honors were that he had received. And the general said to him, "You should be proud, son." And Ed said, "You got to be shitting me, sir." And he went to the stockade immediately. Because what he said to me was, I observed atrocities every day, and I committed atrocities. And I just can't live, with myself or what I observed. So here we are all these years later. We have thousands and thousands of combat veterans coming home from Iraq and Afghanistan, and I haven't seen any of them in my office. I've had a few Persian Gulf veterans. But I think it's so important that trauma really does impact our inner world. And of course, there's a difference between a combat veteran and someone who's experienced long-term neglect. There's different kinds of trauma, of course. But it's that disintegration of the inner world that's really important. I think I like this method better. So, our basic assumptions, if we're going along in a healthy way in the world, is the world is benevolent. I was telling Paris Stu here that I just came back from 3 weeks in India, in southern India. And I had to assume that the world was benevolent, that if I fell down on the street, somebody would come and help me. We assume we don't have to go to India to assume that. You assume that right out here. Something happens to you, nice people will come, call the ambulance, do whatever. So the world is benevolent. But as I'm talking, you might think about some of your patients who have childhood trauma, where they never really learned that the world was benevolent. because maybe they came from a violent alcoholic family, and when they acted out at school because they were so anxious and they couldn't sit still and do their work, then the teacher was punitive, or the principal was punitive, or that, you know, there wasn't the kind of support that they really needed to begin to know that somewhere, someplace, the world is benevolent. The world is meaningful. Again, you know, back to Ed, the world had lost its meaning for him, particularly when he got home and found out that it was all kind of a hoax anyway. You know, more and more has come out about the conflict in Vietnam. Now, I should back up and tell you, I'm the daughter of a Marine Corps fighter pilot, and I moved to Newport Beach as a young child. I was 5 when we moved to Newport Beach because my dad was a fighter pilot out of El Toro. So I'm not speaking against the military. I'm a Marine Corps brat, but I'm just saying what's so from my perception. So the world is meaningful. And this comes back also to, well, 2 things come to my mind. I have a number of people coming to my office. I'm a CSAT, a certified sex addiction therapist, where their partner, they have found out that their partner is a sex addict, acting out with prostitutes or online or having a series of affairs. So again, it's about, you know, the shift in that inner world, and is this relationship I have meaningful, or is it all a hoax, and has it always been? And the self is worthy. Back to Ed, I've committed atrocities, right? So I'm no longer worthy. So the DSM identifies 3 main trauma diagnoses. And again, I'm going to talk about some cases as we go along here. So the first one is acute stress disorder, and then post-traumatic stress disorder, then anxiety disorder not otherwise specified. It would appear that in DSM-5, there's going to be an additional trauma diagnosis, either called complex trauma, or I wrote the other one, DES, disorder of extreme stress. And I really liked what I read about this. It said, murky critical events, diffuse and cumulative. So sometimes, you know, there's not some big horror story like the one I just told you about Ed. There's sort of what I call low-level but long-term stressors. Maybe there's been in a child's life a parent who was ill for a long period of time. I've had a number of patients over the years who, when they were born, their mother already had cancer or developed it very soon and was sick over a long period of time, or a dad for that matter. So that would be that, you know, sort of low-level but long-term disturbance. I think that oftentimes adult children of alcoholics come under this category, where there's no one event that you can identify or one discrete period of time. It's this long time where people have come to be hyper alert. So I'm sure you've had this experience. I have ACAs come to my office and say, I knew if my mother was drunk by the way the charms on her bracelet sounded. I knew if my dad was drunk by the way the garage door closed. I could hear it, that hypersensitivity. So acute stress obviously is something that has happened pretty immediately. Had a woman recently who I'd seen in therapy probably 20 years ago come back to me because she had 2 brothers die within 2 weeks of each other. She was one of 8 kids. These were her 2 older brothers that she considered her protectors. But here's the interesting thing about that, and it's important to look at with acute stress, and that is we had done work before, years before, 20 years before, on her being molested by her father. And these 2 brothers protected her, but also denied the abuse. So what happened, these 2 brothers die 2 weeks apart, back east someplace, and all the old stuff is re-stimulated. Now, we're not going to have to spend years, like we did before, you know, working on it, but sometimes acute stress is just acute stress. You know, there's been a car accident or some discrete thing, but sometimes it's recapitulating old trauma. You all know about post-traumatic stress disorder. This is years down the road. All of a sudden, symptoms come. And I find that a lot, that if I start digging with people who are having current depression or anxiety, that if I really look, I'm going to find old trauma. I think most of you, how many of you are doing addiction work? Almost everybody, yeah. So when there's addiction of any kind, whatever it is, I'm always looking for what's the trauma? Where did this start? Which we'll get to in the chart. So, stages of treatment. You have this on your chart. First thing, of course, is crisis stabilization. How are we going to help this person just settle down and be able to breathe and take care of themselves? So in crisis stabilization, I'm an outpatient practitioner. Of course, I'm evaluating for, can this person remain an outpatient, or do they need a higher level of care? And if so, what is that going to be? But if they're going to stay with me in outpatient treatment, we're going to talk initially about very, very simple things like, are you sleeping? And if you aren't, what can we do about that? What kind of sleep hygiene do we need to take a look at? And are you exercising? And if you're not, and some of my people have never really exercised, and I start by saying, walk 10 minutes that way and walk 10 minutes back, and we're going to call that exercise for the day. So I'm very, very specific about, we're going to get started. And I'd like your exercise to be outdoors, if possible. I was talking with Jessica earlier about doing nature therapy, being outdoors. I think nature is extremely healing. And I will actually say to people, I want your exercise to be outdoors, and let's make a plan for it. And then I'll say, you know, you're undergoing change in your life, and the thing that knows the most about change is nature, because it's changing all the time. And I'll talk a little bit about whatever season it has to be. In Northern California, it rains a lot. I mean, a lot. So people can't always be outdoors, but if they can be, I ask them to be outdoors for an hour a day doing exercise. I ask about their nutrition. I mean, is this the basics? Are you getting enough B vitamins? I mean, are you eating whole foods, or are you eating every meal at Taco Bell? So I'm trying to get them to have a healthy basis, a healthy foundation. And I'm also, of course, doing all the self-soothing kinds of things, etc. So obviously, if there are issues of addiction, and if the person is willing in the moment, sometimes it takes a while, as you know, for people to be willing, I'm immediately referring them to a 12-step program, possibly to some kind of intensive outpatient program, depending. So the next stage is the grieving, the losses. This is the you know, here's what's happened to me as a result of this turn of events. So many of our patients with alcoholism addiction have lost a wife or children or jobs, or they've lost their self-esteem, certainly. So it's important to be talking about the losses, but I'm always looking back. I think these stages I'm weaving back and forth throughout the course of therapy. So sometimes we're back in crisis again, and sometimes we're back in grieving. Then I'm looking at the survival responses, because particularly people, well, I'm not going to say that, that's not right. I was going to say particularly people who've grown up in dysfunctional families, alcoholic families, families where there was significant illness, mental illness, or physical illness, or neglect. They have survival responses that got them through. They were adaptive. People, I was telling somebody earlier, I have done a fair amount of child custody work, and people will say, for children of divorce, oh, you know, the children are resilient. Well, children are adaptive. We're all adaptive to whatever our environment is, and it will help us get through whatever our situation is, but it's not very necessarily healthy in the adult world, in the job world, in the relational world. So I'm trying to help people look at, okay, we've done the grieving, and we've done the looking at what other people's responsibilities were here, all right, and how they may have failed. If you're not aware, in the military, many men and women are encouraged to drink a lot of alcohol. And I've had many a service member tell me, my commanding officer, encouraged me to use drugs. It's hard to believe, but I've heard it enough times to believe it. So we've done enough talking about what they did. The survival responses are, here's what I do that gets in my own way. here's what I do that's no longer functional, you know, in my relationships. And then lastly, family of origin and other relationships. Now, I put that last, but as I said, I do the genogram the very first day. And I'm trying to dig up what went on in that family. First of all, I want to know, is there any support for this person from their family? Who is their family and what are they like? And if this person's in treatment here at Sovereign Health, what are they going home to? Not just in their immediate, you know, home life, but in their extended family. So I know you all know patients that you've had that get treatment for their alcoholism or their drug addiction and go home to an addicted spouse, or maybe not even an addicted spouse, but a drinking spouse. Or a family where every family event is around alcohol. So I want to know about all of that, and we're going to work on it a little bit at a time throughout. Please ask questions.
Do you actually have them draw out a genogram in that first session, or are you kind of?
I do it. I sit there and draw it, and I say, you know, I don't usually take notes during sessions, but I will say to them, you know, this is the first session, and I want to remember. So I'm going to make a little picture of your family. And I don't show it to them on purpose, but if they want to see it, I'm happy to let them see it. And I'm writing down every single thing they say. I usually ask very specific questions. What did your father do for a living? What did your mother do for a living? What was he like? Characterize him for me. Now, I'm well aware this is this person's perception. It may or may not be somebody else's perception, but this is their interject. Okay? So let's see, trauma and terror of our own fragility. Isn't that the truth with trauma? You know, we come up against trauma, whatever that is, and we find out that, you know, we're fragile. I had this interesting experience when I was in India that I think illustrates this. When I got there, I misread the directions on one of the medications that I was taking, and I took 3 times the amount that you were supposed to take, and I was really sick. And if I could have gone home, I would have gone home. But, you know, getting on the airplane again for another huge long flight across the world just was not an option. But what happened for me was I got very, very regressed. And I was regressed to being 4 years old. When I was 4 years old, I almost died in a hospital in North Carolina, a military hospital. And I was right there again. And fortunately, I had 2 wonderful therapists from the University of Arkansas with me, and they, you know, glued me back together. And I was crying, and I said to this one, Betty Everett, Betty, I have been working on this trauma since, you know, my early 20s. And she said, well, yes, and you're going to keep working on it from time to time, Sonnee, especially when you're in those kind of difficult circumstances like here where you're really sick and there's no one to take care of you except me and Susan. So, you know, I'm saying that because I felt, you know, totally out of control and very regressed and very aware of being a child in that bed, you know, with my family around me because the chaplain had come to gather my family to say goodbye. So disillusionment and change in our assumptive world. We talked about the assumptions. I certainly, again, I'm going to refer to sex addiction and the partners thereof. The partners have a huge disillusionment with their assumptive world. You know, what they assumed was so is not so. And processing new data, new information coming in, and how am I going to make sense of that, integrate it, right? Rebuilding assumptions, interpreting the traumatic experience in a way that can be useful for me. Do you guys do that? Do you try to find a way? And I don't mean some Pollyannish, oh, you're going to be stronger for this, you know, what doesn't kill you makes you strong. I don't mean like that, but finding a way to make use of it so that the traumatic experience does have some usefulness. It's not just, you know, a whole waste. And that requires spiritual work. Now that brings me back to Ed, our Vietnam veteran. Ed, on one of the sessions, brought in a scrapbook that he had kept. So I'm not going to use the magic wand. I'm going to set it down. And I can't remember really if I had asked him to do that or if he did that on his own, but here's this big fat scrapbook. And as I'm paging through it, you know, there's some pictures of him as a young man in his uniform and some of his buddies. But here are church programs, pages and pages and pages of programs from church services. You know, you go to church and you get a little program. And, I mean, there were just loads of them. And I said, oh, well, were you raised in a religious family? No. So did you go to church when you were a kid? No. Parents never went to church. So how did you come to have all these programs, and how did you decide to go to church? And he said, I have no memory of ever being in any of these places, Sonnee. I don't know. So here's this man who's completely dissociated, probably a lot of the time that he was in Vietnam. He's got all these church programs that he's carefully pasted in, saved, brought home, but he has no memory of being there. But as we talked about it, he said, I guess I was just looking for somebody to help me and to have something meaningful happen. And to rebuild the assumptions and interpret the traumatic experience. So I would have never known that. He would have never revealed that in therapy if I hadn't. I think what I said to him was, and I often say this to patients, all patients, you know, could you bring 10 or 12 photographs of yourself at various ages? You know, bring a kindergarten picture, bring a high school graduation picture, bring a wedding, and you know, some of them that might show your family. And then we look at them together, and you can tell an awful lot from photographs. You know, how do the people look, who sits next to who, if somebody has their hand on somebody else, what do the hands look like? So I think that's what I had done. I had asked him to bring his photographs, and all these church programs were in there. So it was a nice inroad for me, and it was a valuable piece of information. So trauma has a dual nature. There's damage to the identity that comes from the original trauma-causing event. And then there's the damage from the survival responses. So we really have to look at both. And to be careful not to be shaming about the survival responses, to be able to say, you did a really good job in a really unimaginably difficult situation. And now it's time to learn some new skills that will serve you better now, particularly in relationships, you know. But relationships of all kind, not just intimate relationship, but, you know, relationships on the job and with the next door neighbor and so forth. So I brought this nifty chart, which you all have. And this is trauma resolution in a nutshell. So we talked about crisis stabilization. And I really like this. Look what's happening to me. I'm a mess. I have claustrophobia, or I have agoraphobia, or I can't fly anymore, whatever it is. I'm so depressed I can't get out of bed. So look what's happening to me. And the clinical work is evaluation. You know, that's the genogram, getting the whole story as best you can. I said to somebody earlier, I think it was Donna, when I was a beginning therapist, my supervisor, who was an older woman at that time and very, very seasoned, said, you're taking history until the day you terminate. And it's really true. So as you're doing the evaluation, just know you're not going to get it all at once. It's going to oop out over a long period of time, and on the last day when you're terminating, you're going to learn something new. Crisis management and commitment to treatment and the readiness for trauma work. The commitment to treatment is really important because sometimes people come to therapy and they don't really understand what an effort it's going to be. It's not an easy thing. It's a wonderful thing, but it's not an easy thing. And I remember a woman said to me, I am so angry, I'm so angry. Everybody I know is going on cruises and I'm going to fucking therapy. It's time consuming, it's expensive, and a lot of times you don't feel better immediately. In fact, you feel a lot worse before you feel better. So I try to help people understand, you know, this is going to be a bit of a journey. And one of my supervisors said, I tell people life is a race between senility and maturity. Isn't that good? And he said, and then I tell them, and I know the way, and I'll go with you as long as you want to go with me. Okay? And then the other thing that's so important, I think a lot of times gets missed, does this person have the constitutional makeup to be able to tolerate the trauma work? Are we just going to kind of glue this person back together, or can we really do deeper work? And that is a really critical evaluation. And you just have to, I mean, there's no magic answer about it, but it's certainly something to consider, particularly with people who have a lot of borderline features. And you know, people who've been severely traumatized look really borderline, and maybe they are. You know, it depends on what their earlier life was like, right? So I have my Ed, who comes from this terrible alcoholic family, you know, and then all the Vietnam trauma on top of it, and then all the trauma he did to himself on top of that. I had to really decide, you know, how deep can we go here? And am I just going to help him really fall apart, which I do not want to do, all right? So that's important. So these are the psychosocial skills: crisis survival, self-care, boundaries, so critical. So many of our patients have no boundaries. They've not been allowed to have boundaries. They've not been allowed to say no. And they've not been allowed to discern who they like and who they don't like. I had a woman say to me, I just thought if you like me, oh good, then I like you immediately. I mean, you could be Jack the Ripper, but if you like me, I like you. So having boundaries and better discernment is important. Safety, empowerment to come to his or her own assistance. How are you going to help yourself? And are you allowed to say, no, I'm not coming for Christmas this year because I don't want to be around all that chaos or all that drinking or whatever? That I'm allowed to empower myself to do what it's going to take for me. And I'm always giving people things to read. Sometimes I have them do readings about trauma related to their particular situation. A woman said in one of my groups, said to me the other day, I used the book Trauma and Recovery as my Bible. I carried it in my purse everywhere I went. Other people tell me they love Peter Levine's book, Waking the Tiger. So, you know, you can find something that sort of fits that particular person that will be helpful to them. And in group therapy, I put the stages of group therapy out here on the end. So if you're going to have your person in group, and I sometimes do this when somebody's in crisis because I'm trying to get a little family around them that will support them while they kind of get on their feet. But it's the 4 G's of group therapy: groping. So, and I will tell them ahead of time, okay, here's what's going to happen in group. You're going to go to group and blah, 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 blah. And you're going to look around and you're going to say to yourself, I do not belong in this group because these people are all way sicker than me and their problems are just way beyond. That's one response. The other response is, I do not belong here because these people are so well. I mean, they really have it together and I'm a mess. So I said, you know, it's just kind of in the beginning, and it's going to take a while to get to know who people are and their names and their story and so forth, and you're going to be groping, and it's really the way it's supposed to be. Phase 2, grieving the trauma-related losses. So we've got stability under us, we have resources, and now we're going to talk about, look what I've been through. I'm going to tell the stories. You can do it. I do not do this in a really tight, lots of forms kind of way. I think it's great to do it that way with a workbook perhaps or whatever. It's just doesn't happen to be my way, but you might think about, how am I going to do my groups and my individual therapy? Will this person do better with more structure where they're working in a workbook and coming back and reporting in? But they're going to be telling the story of what happened to them. And probably most likely going to be in a group. They're going to be talking in group about what went on back then and what's going on now. I'm going to be working a lot with them on emotional feelings and physical body, somatic feelings, so that they get the two hooked up. Now that said, sometimes if I have a person who's just all about their emotions, I'm trying to get them hooked up to their head. So I do think that sometimes therapists make this mistake of saying feel, feel, feel. And, you know, if you have somebody who's, you know, been to jail for domestic violence, really the last thing you want is to have him feeling. You want to have him have his logic and reason engaged and be able to manage and put the lid on those feelings. And I don't mean repress, I mean manage and control and find other outlets. So that's the other piece, is I want them to be connected, heart and mind, all right, and body. Individual work throughout as needed, and sometimes as needed in my neck of the woods means can they afford it? I keep my groups extremely affordable, so that I tell people, you know what, I know you can go down to the Safeway and panhandle $45 a week if you have to, so it's really about your commitment. Okay, so they're going to learn self-soothing, they're going to learn emotion regulation, they're going to be learning about trauma and grief and codependency. I think most of our patients, probably 99.9%, if they have trauma in their life, have issues of codependency. And that comes in so many forms, but it's typically some sort of, I'm going to call it and go out on a limb here and say some sort of narcissistic wound where I so need your attention, I so need your affirmation, I so need to be valuable to you. And you have to think I'm terrific or else I can't live. So we're really working on the codependency part. And in this stage of group therapy, I call it grouping. I love this group. This is the best thing that ever happened to me. I love you, Sonnee, and I love them. And we're a club, and we're a family, and this is just the best. So that's good, because that means there's bonding happening, you know, and the person's kind of getting a little comfortable, which is a good thing if you've been on edge, you know, for 20 years. So the grouping phase.
So, Sonnee,
Yeah.
I mean, groups here are throughout, and I love that. But at what point do you or don't you decide that someone's ready or not ready?
It's a good question, and it's really variable. So there's not an easy answer. Sometimes I get a person who is so, what's the right word? I want to use the word bland, but that sounds pejorative, and I don't mean it that way. They are so flat. Yeah. That they don't really know how to do individual therapy. I mean, I can yap as fast as I can for the hour, but they're like, they don't really know how to use therapy. And I will put that person in group, and I don't care if they don't say a thing for a year, because they get to observe other people talking back and forth, the modeling that happens in group. And, you know, they get an A+ in listening, but kind of an F in participation, you know what I mean? But that's okay, because they're learning how to do it.
Do you try to draw them out, or do you just let them be?
No, what I do in my groups is we do a check-in, so we go do a brief, like a 2-minute check-in, go around, and I say to them, I want every person's voice to be heard today. Your voice is precious. I want to hear what you have to say. And if you want to pass, that's all right. I make it okay. You can say, you know, I just want to pass today. Okay. Maybe next week, and carry on, because the last thing I want to do is increase that intense self-consciousness. By the way, self-consciousness leads to self-absorption, and it can look very narcissistic when it really is not about narcissism. It's about this intense anxiety and self-absorption. If I am just up here and I am such racked with nerves, I can't really look out at all of you and think about you, you know. So some people will be terrified to go to group. They just can't do it. I'll let that be. Some people, I'm sure you've noticed, absolutely will not go to a 12-step program. It's too terrifying. It is too terrifying. And I may have them in individual therapy. I have one man now that I've had in individual therapy twice a week for a long time. Just now he's been able to go to 2 AA meetings, spaced very far apart. They're very triggering for him, because his anxiety is so high. And you know, one thing that happens in a group, if I'm one-on-one with you as a patient, I can keep my eye on you, especially if I'm an incredibly good and I'm sensitive and I've watched my parents my whole life to make sure I'm not going to get hit. And so I can tell if I'm pleasing you or not, if you like the content of what I'm talking about, and I'll keep doing that little dance with you till kingdom come, but we won't make progress. If I put you in group, you'll be very anxious, and sometimes people who are very codependent get distressed in group because they can't keep their eye on everybody to make sure that everybody is pleased and happy with what they're doing. And they'll get very, very anxious. The other thing that happens, and it comes back to the boundary work, is a lot of times people who've been traumatized do not have emotional boundaries. So if you are talking about the terrible thing that happened between you and your wife last week, I am taking it on and feeling all those feelings, and I just can't. So we have to work on emotional boundaries. You need to remind yourself during group, that is happening to him. It is not happening to me. I actually had a nice time with my husband this week, and it's kind of going well there. So, and I would talk about that right out loud when they say, oh, this is too much, I'm taking it on. I say, well, it's about emotional boundaries, and you can learn to do it. You just have to stay in yourself. I was telling Jessica earlier that I did a 2-year shamanic training. Sometimes I get out my Florida water and I say, okay, put a little Florida water in your hands, now smell it, now put it around you and make a boundary around you with, I mean, it's imaginary, of course, but I'll do something so that they get the idea of having emotional boundaries. Okay, so looking at survival responses or the symptoms, look what I've done to myself. So I'm starting to develop accountability about me. Sometimes people will say, well, it was, you know, these people have, if we're blaming, if it's all my father's fault because he left, you know, and so that's why I behave this way, and that's why I cry and scream and carry on and accuse you of things when you're trying to drive away to go to work or to see a friend. If I keep blaming him, well, this is the reason, you know, I have abandonment issues. I'm going to try and bring it back to, okay, so you do. Now, what about you? And how can we shift that? Because now, you know, it's not so useful. So I'm trying to bring the locus of control inside. This is my life. I have my choices, and I am at the outcome of my choices. Every choice I make, good, bad, or otherwise, is going to have consequences. If I take this job instead of this job, I go down that road and I have those benefits, but I don't get the benefit of whatever was over here. And that's the way life is. So I am now really helping people say, I am the creator of my life. I have my history. I have what happened to me. I know all that. But now I am at choice. Am I going to eat that brownie or am I not? Am I going to take that drink or am I not? Am I going to have that affair or am I not? Am I going to take this job or that job? I'm going to use my judgment. Am I going to go to the Christmas party or am I going to decline? Every single choice. Am I going to have the baby or not have the baby? You know? If I have the baby, what am I going to do with it? Once I've got, you know, all these choices, they're all mine. So accountability, learning to trust myself. And, you know, I always do this, you probably have heard this little thing, wisdom comes from good judgment comes from experience comes from bad judgment. I give a lot of permission for, well, when you start making your own decisions, there will be mistakes, there will be things that you regret. We don't always do the right thing every single time, but you're adding to your own experience base, so you're learning more and more about life. You're learning who to trust and who not to trust. This is a big one for kids who grew up in dysfunctional homes. Who can I trust? And it usually goes to one of the extremes, which happens a lot with trauma in general. I either trust everybody, and I will bring home Jack the Ripper because he needed a place to sleep, or I trust nobody, and I'm avoidant and don't really have relationships very much, except maybe on the internet. So I'm learning interpersonal skills, and there's nothing better than group therapy for learning interpersonal skills. How to be quiet when other people are talking, how to use my words so that when I have something to confront you about, a concern that I have, I don't end up making you an enemy for life. I mean, all those kinds of skills that come up in group therapy. So I do psychoeducation around process addictions because alcohol and drugs and sex are not the only things that we get addicted to. Shopping, working, computer games. And I think sometimes as therapists, well, I'll back up and say, I had a wonderful graduate level class in my doctoral program called Advanced Alcoholism Studies with a man named Dr. David Berenson, who'd been with NIMH for years. And his critique to me was, Sonnee, you just want people to get sober too much. You want it too much. Everybody gets sober eventually, he said. Some people just have the good grace to do it before they die. So I find for myself, sometimes I want, you can't go on the computer all day long, you know, but they have to. I mean, that's how they cope. And so we start just gradually. Well, maybe you could just be on the computer for 3 hours instead of 5. So sometimes those things that people are using to soothe themselves, I mean, they almost come under the heading of defenses. You have to be careful how quickly you remove them so that you don't have somebody, again, regressing and falling apart. This is the griping phase sometimes. I'm sick of this group. I'm sick of you. This is ridiculous. It's gone on too long. And I'm trying to think of a personal thing that has been said to me. None come to my mind, thank God. But you know, sometimes it'll be very personal about the therapist. You think you know everything. You have a perfect life. Whatever form it comes in, is the griping. And I'll say, oh, this is good. This is very, very good. Now you know how to complain when something is not going the way you like it. I mean, again, back to the codependency and the yes, 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 yes. I love you, love you, love you, no matter what you do. So it's important, again, to interpret it for the group. Well, I'm interested in hearing your complaints. Oh, I know one. Sometimes somebody will say to me, you're very judgmental. I am, you guys. I mean, that's a character defect. I can be very judgmental. I just say, you're right. I really can be. I'm so sorry. If you see me doing that, just tell me, you know. I know that about myself. All right, looking at family of origin. Again, this is 4th on the chart, but I think it's integrated throughout. It used to be said in my training, do not touch the family of origin or the trauma for the first year of sobriety. I do not know how to do that because I don't think it can be done, and I don't think that's what's being taught now. But it never worked very well for me. So it's really about, isn't that great? Look how far back this goes. So I'm going to tell you another anecdote. How's our time? Somebody pay attention to the time so I don't go over. Okay, we're doing fine, it looks like. When do we end? 5 minutes. Okay, this is a great anecdote.
We could go on.
We can. People can leave if they need to leave. So I'm just trying to think which one to tell you. There's so many. Well, I'll go to another Vietnam vet, Harold. And Harold decided that he had a dad who went to West Point and was some big decorated honcho and ran the family in a very military way. It was very critical, very, very critical and punishing. And this guy decided his whole life, I just want to make my daddy proud. I'm just going to make my daddy proud. So he too joined the Marines as opposed to the Army because, you know, the few, the proud. And when he got sent to Vietnam, he got chosen to be on the detail that wear their dress blues every day and stand at attention outside the military establishment in Saigon. And he thought, I'm never going to make my dad proud this way. Now this all came out, by the way, way down the line because we were working on alcoholism. So he wrote his congressman, bad idea, and said, I didn't come to Vietnam to stand around in my dress blues sweating. I came to Vietnam to fight like a man. And so the congressman wrote a letter to the commanding officer who was not pleased. If you've ever been in the military, you do not do that. You do not go above your commanding officer. All hell breaks loose. Commanding officer called him in and said, oh, so you want to see combat, do you? I'll show you. Good. You can go up on the DMZ with the 2nd Marines. Well, when Harold got there, I mean, they were using dead bodies for walls, and I mean, it was just a nightmare. And when I asked him, what's the meaning of that? What, you know, he said, my dad always told me I couldn't make decisions, that I'd never amount to anything. and I made this one big decision. By the way, his wife was complaining they couldn't make decisions, couldn't decide anything, couldn't decide anything. I made this one decision, and oh my God, it was terrible. So look how far back it goes, you know, way, 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 way back. Another person probably would have been relieved to be standing there in their dress blues and would have been just fine. So we're going to talk about invalidation and the trauma in childhood and adolescence. Oftentimes, as you know, it's not within the family, it's on the playground or whatever. You heard Dr. Snyder mention that I had written a book about African American women, and I interviewed close to 40 African American women for my book, all of them highly accomplished. Jocelyn Elders, our former Surgeon General, Loretta Devine, the movie star, just a wide variety, Tupac Shakur, Sister Sechua. And when there is prejudice of any kind, if you belong to a marginalized group, trust me, there's trauma. So if you are treating people who are gay or lesbian, who are a racial minority, any kind of group that is marginalized or where there is prejudice, you really have to start talking about those incidents that oftentimes what I found in writing my book is these women had taken it in stride, but trust me, it had marked them in ways that I don't know that they even quite knew, but I, as a psychologist listening, could see, you know, the bigger picture. So I'm going to go on through and say the last stage in group is growing. And a woman in one of my groups said one day, I have finally figured out, Sonnee, that it doesn't really matter who's in group with me. It really doesn't matter. I am here for myself. And as long as I'm here for myself, it really doesn't matter if I like the other people or I don't like the other people. In fact, it's kind of a good thing if I figure that part out. It's part of my learning to be discerning. And so I'm here for myself and I'm growing. My groups are long-term, interactional. I don't do time-limited groups. I think they're quite wonderful. You know, DBT skills, those kinds of things, so valuable. It's just not what I do. So I'm happy to hear your questions, anybody who wants to stay. In your, yeah, I talked about the cases. In your, this slide and then one after it is in your handout, so it's various references, just a few, certainly not all. If you haven't read Peter Levine's Waking the Tiger, please do. If you have not read Richard Scare's book, The Body Bears the Burden, please get it. Every time you have someone come into your office with fibromyalgia, you're looking at trauma. And the person usually doesn't know it. And they've been to 52 million doctors and taken all kinds of medication, and that's traumatic, by the way. So if you have questions, thank you. Thank you. By the way, this slide presentation was made by a woman who has very significant trauma in her life, significant. And so she's a graphic designer. She went to Georgetown and, you know, was very accomplished in her own right, but completely debilitated with trauma initially. And now she's starting to work again. So she does my PowerPoint presentations, and we exchange. She gets to come to group. I get to have these beautiful presentations. So anything you want to ask or say? Comments? Yes?
Yeah, I've often felt in addiction work that alcoholism and other drug dependence in the process of recovery is in and of itself a traumatic environment.
Oh, yes.
Process of change from the loss of the lifestyle, loss of the drug.
Identity. Who am I?
Identity.
Yeah.
And so in one sense, the idea of acute trauma or post-acute, even post-traumatic stress is related in some way, I think, to the whole addiction.
I think definitely. I absolutely agree. Yeah. I absolutely agree. And the codependency is almost always underneath the addiction, you know, and that's that wounded self, you know. Yeah. Yes.
I've heard it said that 80% of people with addictive problems have post-traumatic stress.
You know, I wrote a couple things down that I didn't say, but this is important. 98% of hospitalized psychiatric patients are trauma victims. I got this right off the HHS website. Dissociation occurs in 1% of the general population, but 5 to 20% of trauma survivors. So I didn't even talk about this part. Like I said, we could talk for a week. So, yeah. Yeah, of course.
Can you mention those books again that you recommended?
Waking the Tiger, Peter Levine. It's somatic work. He really works with the body. And if you haven't heard him speak, it's quite worth your while. He's an amazing presenter. He really talks about the physical aspects of trauma and how trauma is carried in the body and how to release that. This is one other thing I might say. You know, none of us can do it all. You know, it's just impossible. So it's so important to have people that you know to refer to. I don't do that kind of body work, but I know from my own experience how valuable it is. It's really valuable. So have your resources available.
I sponsor a lot of women that have sexual abuse,
Mm-hmm.
and I've found that there's only like a certain amount of recovery. Like I don't know if, so I'm wondering, do you always just have full hope for full recovery?
No.
You kind of be more realistic. Like,
Yeah, you know, early in my career, I thought, we can fix that. And now I don't think so. I think some things we learn to manage.
okay.
And I tell people just exactly that. You know, when something really challenging, by the way, Diana Russell's study said 1 in 3 women over the age of 18 has been sexually abused in their, I mean, that's, and she did a random study where she just picked names, every 3rd name in the phone book or something, so it's truly random. No, I think they're going to manage it. And my ed is going to manage it. I'm going to say one more thing. I'm part of a consortium of 11 national women. Our book called Making Advances about female sex and love addicts is coming out in September at the SASH convention in San Antonio. And one of the women in the book was in a terrible automobile accident with her boyfriend as a late teenager. And she said, you know what? You can do EMDR to me till the cows come home. I will never forget that decapitated boyfriend. It's not going away. I have to learn to deal with it. You know, some things we just have to do the best we can, learn our self-soothing skills, and carry on.
What kind of goes to the point of what is the definition of true recovery?
That's right.
I mean, what does that mean?
What does that mean?
I don't know what that means. Nirvana?
Yeah, exactly. I do think, I didn't talk about it today. Jessica asked me about it and I spoke to her about it for about a half an hour. The spiritual component is so important. I really try to help people find their own spiritual path. If you come to my office, it's very eclectic. I have a gorgeous Kuan Yin, I have the Blessed Virgin, you name it, I've got it. A lot of Native American antiques. So I think it's important to make, you know, the space that you're working in a healing space that represents, you know, healing for you and where people are going to come in and be comfortable. It's always interesting also to see what people focus on. Oh, you're into all that Indian stuff, and I'm thinking, well, there's the Kuan Yin's this big, you know. So, but it's just, you know, it's all diagnostic and interesting, and so that's important. Anything else?
We'd really like to thank you.
Oh, thank you. It's great to be invited. Thanks. I brought, I think you guys maybe saw this about the book. It's my book, so of course I'm very attached to it. But it's also great stories of resilience and transformation. So if you're interested in 31 great stories, see me.
Okay.
Thank you so much.
Oh, you're welcome.
Really informative.
Good,
Wonderful.
good.
Great speaker.
If anybody here who wants to be on my mailing list for workshops,
I
leave me
would.
your card and I'll put you on the mailing list.